Genetics, the genome, was a monumental event to be understood. In the 20th century, and in prostate disease, particularly prostate cancer, it's to treat or not to treat. This represents an individual who has prostate cancer, and so does this. But you probably can tell by looking at them that there's something different about them. Some cancers are really aggressive, and some not. The large number of men who are diagnosed as having prostate cancer in a year's time will have treatment that comes about because of the angst of the reality that I have cancer. And I got to do something about it. And you're right, you do. The question is what? Let's talk about the grading system. This is the Gleason grading system. The point I want to make, though, is these cells are very much like normal prostate cells. If we took this and gave it to, I would say, a relatively experienced pathologist, can you tell me what organ that's from? He would probably have trouble telling you. That's the difference between well-differentiated and very de-differentiated tumor. This is much more aggressive than this is. A method of staging. A T2A lesion means that a portion, a part, possibly a half, maybe even just a focus of disease exists in this prostate. A T2B means that we have disease throughout the prostate, but contained within the boundaries of the prostate. There's one thing that's universal about cancer. Early diagnosis is the key to success in management. What PSA really does is it tells you something. Something's going on. PSA is a useful marker, and that's all it is. National Comprehensive Cancer Network. What it is a way to develop risk groups. Every year, 250,000 men are diagnosed as having prostate cancer in the United States. A significant number of those people are overtreated. Some of them are undertreated. Genetics deals with looking at a solitary gene and trying to figure out what that one gene does. Genomics is looking at a group of genes and trying to figure out what biologic process did these genes influence. We have a knowledge now by our clinical pathologic staging that this individual is high risk and this individual is low risk. Is that good enough? Could we do better? So back to our question. To treat or not to treat, we have to know low or high risk. Genomic Health has put together a tremendous research organization. So let's stop and just for a moment do a little case study. Let's say we have somebody in their mid to late 60s who was found to have an elevated PSA. Ultimately, they were worked up, they had a biopsy, and they had the diagnosis of prostate cancer. But we really need to know some more about these cells, and we need to understand this history of this individual and the progression of his disease. So we're going to send it to Genomic Health, and we're going to tell them about all the information we've gathered. We're going to have them do an assay on the tumor that came from the biopsy to understand the genetic makeup of that particular set of tumor cells. We're going to be able to confirm that this person is higher risk and this is lower risk by accruing some genetic information. I want to talk to you about prostate cancer risk. I will try to keep it simple. Clinical information is what we're all familiar with. We're examined, have blood tests, x-rays, sometimes biopsies are done. Biologic risk is in large represented by genomics, which is a group of genes and understanding what those genes do for us or to us as individuals. We are going to apply these principles to a U.S. metropolitan population of patients who have prostate cancer. The initial distribution here is clinical risk categories, and this shows patients with very low risk make up approximately 10% of the group. Low risk, 50%, and intermediate risk, roughly 40%. The GPS, or Genomic Prostate Score, combines clinical and genomic information, and that will change the way the patient's risk is distributed. Here we can see that roughly 30% of low-risk patients become very low risk. 10% move into the intermediate risk category. Some of the very low risk moves to low risk or intermediate risk. Some in intermediate risk move down to the low risk definition. What we see now is a significant change in the distribution of risk within this group. The very low risk is now 26%, the low risk 31%, and the intermediate risk 44%. We can take this information and match this to the appropriate unique therapies for each of these patients. In the very low risk, active surveillance is clearly the treatment of choice with good outcomes in 84%. The low risk category, with appropriate treatment, such as minimally invasive therapies, have very good outcomes of 75%. In intermediate risk group, we use yet more assertive therapies such as radiation or radical prostatectomy, and approximately 60% have very good outcomes. What we've done with the Genomic Prostate Score is combine clinical and genetic factors in determining risk. This is very accurate and gives us a precise information by which to assign unique therapies to individual patients at risk with prostate cancer. Here, with a GPS score of 8, the risk is very low, and active surveillance is the most appropriate therapy. As we move across the gradient, the risk increases. When appropriate unique therapies or interventions are used, in these cases, the outcomes are quite good. We have the tools today to not only make the diagnosis, understand the problem, but treat the problem so that person who's saying to himself, that all sounds great, but I got cancer, what do I do about it? We can tell them more today than we could just 12 months ago. We have information on access to this GAP program. We can make this information available